plastic surgery topics and of course answer all your questions, okay? So today we're going to talk about an extremely important topic. We're going to talk about blood clots, okay? Blood clots, okay? So we're going to delve kind of really deep into it. We're going to talk about definitions, what they are, how they happen, how to try to prevent them, how to diagnose them, and how to treat them, okay? So we're really going to dive in deep here. And we're going to talk also a lot about the things that we do to try to identify, the risk for blood clot as well. All right. And then, of course, once as we go through this, I'm happy to answer any questions. And of course, once we're done, we can continue talking about this, or I can answer questions really related to any plastic surgery topic that you might have. All right. So let's delve into it. So blood clots. What do we mean when we're talking about blood clots? We're mainly talking about two main things. One is your DVT, and that stands for deep vein thrombosis, and we typically see those in the lower extremities, so in the legs, and actually most commonly we see it in the back of the calf. That's the number one place where we see that. That's your DVT. And then we have your PE. Your PE stands for pulmonary embolus, okay? And when we're talking about it in this setting, we're talking about a clot basically that either forms in the vessels of the lung, or that has been dislodged from, say, a DVT. It kind of then travels from the leg all the way up to the lung, causing major issues, okay? And we're talking today, like I said, about clots. We're not talking about fat embolism, okay? That's a completely different subject that, of course, we can discuss at another time, all right? So, what are the main things, what are the three main categories that can lead to clotting, okay? This is called Virchow's triad. Virchow's triad consists of number one, and probably the most important one, is stasis. That means the blood is not moving around, okay? So when there's stasis, the blood is not moving around and tends to want to then just kind of clot, okay? So that's number one. Number two is what's called a hypercoagulable state, all right? So any condition that makes it so that you clot easier than you normally would, okay? That's a hypercoagulable state. And then number three is vessel injury. By this we mean mostly injury to the inner lining of your blood vessels, of your veins, okay? And there's certain things that we do that actually injure this lining that can lead to clots, okay? So these are the three main categories, okay? And so when you have one or two or three of these, then the propensity to clot is higher, okay? And then that can certainly lead to your DVT, and then if that dislodges, it can then lead to a pulmonary embolism. Though it is possible to have a PE without a DVT. So that's a possibility as well, okay? All right, so what are then the risk factors for this? What are the risk factors for clots, okay? So one very important risk factor is actually estrogen, all right? So if you're taking estrogen like oral contraceptives, that will increase your risk for clotting, okay? And so that's why we have all our patients stop any oral contraceptives, any estrogen-based contraceptive actually, whether it's oral, injected, implanted, anything with estrogen, you have to stop that 30 days before surgery up until 30 days after surgery, okay? That is a requirement, and we tell all our patients to do this, all right? So you gotta stop that estrogen, all right? The next one, which is also controlled by the patient, is nicotine. So nicotine, okay, will also increase your risk for clots, and that's why we tell all our patients that they gotta stop smoking, they gotta stop anything with nicotine, so smoking, vaping, nicotine gum, etc. Anything that has nicotine, you also have to stop that 30 days before surgery to 30 days after surgery, okay? Nicotine is a risk factor for multiple things, but certainly blood clots, heart disease, heart attacks, poor wound healing, wound breakdown, skin necrosis, fat necrosis. It is just a terrible, terrible thing. Please do not have nicotine near your system around the time of surgery. And we're talking about first-hand nicotine and second-hand nicotine. If it's in your system, it's going to be bad. Okay? All right. The next one that's important on here is altitude. Okay, so obviously multiple studies have shown that if you are at a high altitude, for example, an airplane, and the way that there's, the cabin is pressurized, and the fact that you can't move around a lot, that's going to increase your risk for blood clots. And of course, we have many patients that are coming in from out of town. They're flying in, they're flying back home, and of course, being on a flight can increase the risk of a blood clot, especially if you leave too early. That's why it's incredibly important that nobody leaves before post-op day 5. Okay, the closer you are to your surgery, the higher the risk that you're going to get a clot on the plane. And that's why we have all our patients stay for a minimum of 5 days. If you can stay longer, even better. But if you leave before those 5 days, then you are officially leaving what's called AMA, against medical advice, okay? Because your risk for clot is way too high, all right? Now, next we have cancer. Okay, so we're doing elective surgery here, so we're not going to be doing anyone with active cancer, but this is more important for those patients that, where we did reconstruction. I worked in Cleveland Clinic, Florida for 5 years doing reconstructive plastic surgery, and so that became a factor there. We had patients that had active or recently had cancer, their risks are going to be higher, okay? General anesthesia, in and of itself, increases your risk for blood clots. Okay, so simply the fact that you're having general anesthesia is going to increase that risk somewhat. Okay, and then let me skip down here. Genetics. Okay, genetics can certainly do it, and these are either genes that we know about, such as factor V Leiden. That's the most common one. Okay, or it could be genes we don't know about. Someone can have a hypercoagulable state and not really know it. Okay. And sometimes you don't even know, a lot of women don't even know until they start trying to have babies. And then they feel, and then they're not able to, okay? And then once they get worked up, it turns out that they have a hypercoagulable state that does not allow them to get pregnant, okay? So factor V Leiden is the most common, but there's multiple others. Okay, there's a lot of these, and of course we can't test for all these, all right? The other thing is autoimmune diseases, which kind of falls within genetics, because a lot of autoimmune diseases are due to genetics. But for example, lupus, okay, and lupus anticoagulants, that's going to increase your risk for clots as well. So not all autoimmune diseases, but certain autoimmune diseases will increase your risk, all right? And last, but incredibly important, one of the most important, is immobility, not moving around. Okay, that goes to number 1 here, stasis, right? If you're not moving around, there's going to be stasis. Okay, you have to, the way that the body's designed and the fact that we can walk, standing up, okay, is because as we move around, we then have a pump action with the muscles in our legs, and that pump action allows the blood to flow back up against gravity, okay? So if you're not moving around, if you're just laying around, okay, or just sitting, then you're going to increase stasis and you're going to increase your risk for blood clots, okay? So as you can see, there's, in terms of the risk here, most of them is basically what the patient controls. So the patient can control whether they're on estrogen or not, whether they're on nicotine or not. They can control when they go back home, which has to be at least post-op day 5, okay? And of course, in mobility, the patient needs to move around. There are some things that you can't control. You can't control if you get cancer, you can't control genetics, you can't control autoimmune disease, all right? And then, this is the one, of course, we put everyone under general anesthesia because that's the only way to perform the surgery, okay? All right, so what's the issue with blood clots, right? What's the issue? Well, clots can lead to many potential issues. They can lead to leg swelling, okay, problems with the circulation in the lower extremities long term. And if it becomes a PE, then you're going to get short of breath, okay, and your what we call the O2 saturation, the oxygenation in your blood, that level is going to start to go down, all right? And if that's not fixed or improved, that's going to be a major problem. It can land you in the hospital, in the intensive care unit, and sometimes if you have what's called a massive PE, a massive pulmonary embolus, that can lead to death. And if it's a massive pulmonary embolus that happens all of a sudden, it can lead to, unfortunately, sudden death. Okay, so it's incredibly important. All right. So you could ask, well, how, or what do we do to try to identify some of these risk factors? Okay. So of course, anyone who comes to Pure before surgery, they're going to go through an extensive number of studies, laboratory studies, of course EKGs, and also every single patient that comes to Pure, 100% of patients that come to Pure are going to get a clearance letter from their primary care doctor. Okay? So we're going to check all the labs, all right? But in those labs, all right, we check your CBC, which is your hemoglobin, your metabolic profile, and we check your bleeding profile, which is your PT, your PTT, and your INR. But these labs tell us if you bleed too much. They don't necessarily tell us if you're clotting too quickly, okay? There are no great studies for that, unfortunately, okay? And then 100% of patients that come to Pure get an EKG, even if you're young and fit, okay? Because one thing that can be like hidden is, say for example, you've had an ischemic event in the heart that you didn't even know about, but that'll come out in your EKG. And if we see that, then we got to investigate that further as to why did that potentially happen. So a lot of times we then move on to a cardiology clearance. All right, and like I just said before, 100% of patients get a medical clearance from the primary care provider, and of course the primary care provider is supposed to know the patient, know their history, and if there's any red flags, they're supposed to, they alert us, and also they don't clear the patient. The only way that a patient can go on to surgery if they're cleared as low risk by the primary care provider. So even moderate risk, we don't go on.
At what week post-op does the risk significantly lower for blood clots?
Okay, so yeah, I'm going to get into that just here in a bit. But I just want to drive that point home. Nobody goes to surgery, a pure plastic surgery, if they're not a low risk. Okay, so if a PCP says you're moderate risk, then we don't proceed. Certainly high risk, we don't proceed. Okay, and nobody has surgery, pure plastic surgery, if they have a history of clots for whatever reason. All right, so whether because you were pregnant, you had a C-section, you had trauma, had an accident, or of course you have a genetic issue like factor V Leiden, okay? Any history of clotting whatsoever, okay? Of course, if we know about it, if either the patient tells us or the PCP tells us, then unfortunately we have to cancel the surgery because we don't want to take on that additional risk, okay? All right, so the question was, when, how to prevent things and when do you know you're quote unquote out of the woods, right?
Mm-hmm.
Okay, so prevention, all right? Again, a lot of the prevention has to do with compliance by the patient, and the number one thing is ambulation. Ambulation is number one, okay? So that means, okay, that when I say I expect you to walk at least 10 minutes every hour, okay, that of course the patient has to do that. All right, you cannot just be sitting around all day. You cannot be laying around all day. That's going to lead to immobility, which leads to stasis, which leads to blood clots. Okay, so ambulation is extremely important, and this is from day one, from day zero actually, from the day of surgery. So from day zero, ambulation is extremely important. Okay, the next thing that we do, and we provide this for all of our tummy tuck and patients. So whether you're getting a tummy tuck alone or a mommy makeover, you're going to get a device called a sequential compression device, SCD, sequential compression device. This goes around the lower extremities, and what it does is a pump action, and it keeps the circulation moving, and it greatly decreases your risk of blood clots. And we give this to 100% of our tummy tuck patients. So you're having tummy tuck by itself, or you're having a mommy makeover, anything that involves a tummy tuck, you're going to get from Pure an SCD device. It's really cool. It's called the Vena Pro. It used to be called the Circle-8. You guys may have heard heard me talk about it before. Now they changed their name to Vena Pro. But it has an 8-hour battery life. It's mobile. It's mobile. You can move around in it. You don't have to be plugged into the wall. Okay, and you can really use it. You should be using it most of the time post-op. You should use it whenever you're sleeping, whenever you're not being very active. So for example, if you're watching TV, watching a movie, something like that. And you got to use it for all sorts of transportation, whether it's a car, an airplane, a train, whatever, it doesn't matter. All sorts of transportation, you have to be using this device. Okay, incredibly, incredibly important. And then the last one is anticoagulation. The most common one that you may have seen is called Lovenox. Okay, Now, I typically don't prescribe Lovenox, all right? Why is that? Because Lovenox has a side effect. The side effect of Lovenox is bleeding. So the risk of bleeding and hematomas, whether it's to the belly, the breast, or whatever it is that we're doing, is higher when you're on Lovenox, okay? And for the types of patients that we treat here, which are generally young, healthy patients with no prior risk of clots, no history of clots, several studies have shown, multiple studies have shown, that the SCDs are just as effective as the anticoagulants, as the Lovenox, okay? But the SCDs, of course, don't have that side effect of bleeding. So that's why we prefer to use the SCDs here. And like I said, 100% of our patients that have a tummy tuck are going to get their SCDs. And that's just as effective as your anticoagulation without the potential negative effect of bleeding. Okay?
Can people without the tummy tuck get that device?
Sure, and everyone can get it. Why do we say specifically mostly for those that are getting tummy tuck? Because that's the aesthetic procedure that has the highest risk of DVTs and PEs. So higher than liposuction, higher than BBL, higher than any breast procedure. Okay, that one of the highest risk of DVT and PE is anything involving a tummy tuck. And so that's why for those patients is that we give them the STDs. However, certainly you can get this for any procedure. And you know who else gets it? So 100% of tummy tucks and 100% of patients that are having a flight that's longer than 3 hours, or that are, or they're traveling in any way that is longer than 3 hours. So if you're getting a BBL and your flight is 3 hours or longer, then you're getting your Vena Pro as well. Does that make sense? So any flight longer than 3 hours, any transportation, any drive, anything longer than 3 hours, then you're going to get your SCDs as well, even if it's not a tummy tuck.
Can you please just elaborate why the 3 hour, if it's longer than 3 hours?
Well, this is all based on research and data and studies, okay? So flights that are longer than 3 hours have been shown to increase the risk of DVTs and PEs. And this is even in just regular folk. Like people that haven't had surgery, didn't go through general anesthesia, just people hopping on a plane. So you'll see, if you look at the literature, especially even longer flights, like the transatlantic flights, 8-hour flights, people can get DVTs and PEs, and you're just a regular person, didn't have surgery, had nothing done. All right, why? Because of the immobility. But maybe you're a smoker, right? Maybe you're a smoker, you're a woman, you're a woman and you're a smoker and you're on a flight and you're not moving around, you could potentially get a DVT and PE in a long flight. And that's why it's advisable that if you're on a long flight, if you want to be super safe, you can get yourself a pair of SCDs, but you definitely want to get up and move around and keep the circulation moving a little bit up and down the aisle of the plane during a long flight. Okay?
I know you touched on Lovenox, but we just have a question about, do you give your patients Lovenox injections?
Right, so that's what I was just talking about now. So I don't, because of the potential risk of bleeding, okay? But I do give them all the SCDs, all right, which multiple studies have demonstrated that it's just as effective as Lovenox for the types of patients that we have here. What I mean by the types of patients that we have here, young, healthy patients that are cleared by their PCP and don't have a history of blood clots. And of course, are not on estrogen and not nicotine, at least as far as we know, because we told them to stop that from 30 days before surgery to 30 days after. So for those types of patients, SCDs are just as effective without potential for bleeding and hematomas. Now, if it's something different, say you're having you're a cancer patient and you're having a mastectomy and a long surgery, because after that you're having a reconstruction. Well, that's a whole different picture, right? Now we're talking about potentially a 10-hour surgery in a cancer patient who has estrogen, because it's a female patient, okay? So for those patients that are in a higher risk category, then yes, you definitely want to be using the Lovenox. But that's a completely different setting than what we are here at Pure. Okay? All right, so now we've gone through this so what are the potential signs? Okay, what are the signs? How can we suspect that there's a possible clot? Well, one of the first signs you might see is that one leg is much more swollen than the other. So I'm not talking about symmetrical swelling, because we're going to expect that after a big liposuction case or BBL, you are going to have swelling. But if all of a sudden one leg becomes a lot more swollen than the other, then that's a risk factor and that should get checked out, okay? The other thing that you may experience is pain in the back of the calf, especially when you're moving your foot up and down. So when you're moving your foot up and down and you develop pain in the back of the calf and that leg is swollen, that's definitely a sign that you need to go to the ER and get checked out, okay? And then if that clot then travels to the lungs, then the next thing you're going to potentially have is shortness of breath, even at rest. Like you're just sitting there, you're not moving around at all, and you're feeling like you just can't catch your breath. Okay, shortness of breath at rest is a very, very serious sign. You got to get to the ER immediately. Okay, and then so those are the signs, potentially for the DVTs and the PEs. And then if you're having that shortness of breath and you happen to have a monitor, O2 sat monitor, and that monitor is anything below, say, 92, then that's a very concerning sign. You get to the ER immediately. Okay, your normal sat should be 95 or above. Okay, so anything certainly below even 92, that's very serious. Okay, so you get yourself to the ER. What's the ER going to do? So the ER has to do two important tests, and I typically recommend that they do both of these. Okay, two important tests. One is your lower extremity ultrasound, venous Doppler. It's basically an ultrasound that looks at the large veins in the legs, and you can tell if there is a DVT in there. Okay, and then the other test is what's called a CT angio of the chest. Okay, and that's what's going to look for your pulmonary embolus. Okay, these are the two very, very important tests that you do once you get to the ER. If both of these are negative, good. Okay, if any of these are positive, then you're going to be typically admitted for treatment. All right, and what is that treatment? That treatment is anticoagulation. And now you're going to probably start with something IV or injectable and then eventually transition to something by mouth. And today there's multiple options, okay? There's heparin, the common IV one is heparin. The injectable ones, common one is Lovenox. The by mouth, there's an old school one called warfarin or Coumadin. And then today we have multiple other options. Eliquis is one of the ones that is being prescribed today. Okay, so options of anticoagulation by mouth, but what you got to know is that it's not short term. You're going to be on these medications for at least 3 to 6 months. At least 3 to 6 months. Some patients even up to a year. Okay, so it's a long-term treatment, and once this happens, then that becomes a part of your medical history, and you must tell any doctor or surgeon in the future about that. Okay? All right, because that's how we know you have a history of clots, and that's how we know, for example, here at Pure, you have a history of clot for any reason, then we're not going to move forward with your surgery. But if we don't know that, then of course, how are we supposed to know? Then you can't hide that from a surgeon or your doctor. Okay, it's extremely important. All right. All right. So one of the things that we get asked a lot is, with this question about the SCDs versus the Lovenox is, how do you kind of stratify your patients in terms of their risk category, okay? So I already mentioned certain things that make you a higher risk versus a lower risk, okay? And there's actually a score that helps you stratify the patient. And this score, and I'll write it up here, is called Caprini score, okay? And then, so based on this Caprini score is what you decide whether A, you're okay with the SCDs, B, you need something stronger like the anticoagulation, and C, if it's something elective like you do here at Pure, whether you just don't do the surgery at all, okay? And there's actually an app, which is a very nice app that you can go to, and here's the address. It's www.mdapp.co/Caprini-score-4-DVT-risk calculator. Okay, that's a lot. All right, but maybe I don't know. We can focus up there. They can look it up. All right, but here's the app. Can you all see that? Can we see that over there?
Yes, we can.
Okay, Caprini score for DVT risk. All right. And then most of our patients, like I said, are young, healthy people, so they're going to be their age is going to be less than 40 or between 41 and 60. All right, but I don't do lipo BBL on anyone that's older than 50, and I don't do tummy tucks or my makeovers on anyone older than 55. Okay, most of our patients are women. Now, oral contraceptives, none of our patients should be on that, right? If they're following our directions, they shouldn't be on it 30 days before to 30 days after. Okay? Pregnancy or postpartum, here it says less than a month, right? We don't operate on anyone who's given birth in less than a month. We always say at least 6 months. So now you're understanding a lot of the rules that we have here at Pure, right? Okay. And then, history of stillborn, that's what I was talking about. That a lot of women don't know that they have a hypercoagulable state until they attempt to have children. And they're having problems having children, and once they look everything up, they're like, oh, there's some sort of genetic factor, some predisposition to a hypercoagulable state. But a lot of women, are walking around and don't know this, okay? Type of surgery, well, pretty much most of our surgeries are over 45 minutes. So we're gonna go to the one that says over 45 minutes, but we're not doing elective major lower extremity surgery because that's what the orthopedic doctors are doing. So risk for DVTs and PEs are higher with orthopedic cases, okay? All right, recent events, again, you're not gonna have any of this if you're having surgery at Pure. You're not gonna have sepsis and pneumonia and leg fractures and strokes, all right? We're obviously not operating on anyone that has any of this, all right? We're not operating on people with factor V Leiden, like I said. We're not operating on people with histories of DVTs and PEs. Lupus, anticoagulant, like I mentioned, okay? We're not operating on any of those, and we expect our patients to move around. Mobility, normal, right? Just because you have surgery doesn't mean you just lay around all day, okay? All right, and then BMI is greater than 25. Well, our BMI limit is 30. My BMI limit is 30, so we're gonna have to click on that. But of course, no one with a myocardial infarction or lung issues, okay? So we're set. So we hit basically a patient that's less than 40 years old, that's female, that's having a major surgery, but there's no recent events or clotting disorders, and they're going to mobilize normally because we expect them to, okay, and no other history. But the BMI will be above 25 typically. It can be, we have patients below 25, but a lot are between 25 and 30, okay? And then we calculate, you hit calculate on that, all right? And it tells you, okay, what the score is, all right? So for this particular patient, as we see here, the score is going to be 3. Okay? So 3 is here, which is moderate. Okay? It's not going to be extremely low because we are doing surgery. So 3 is moderate, and that means they use pneumatic compression devices. You see that there? Pneumatic compression devices. And they're even saying to do it just during your hospitalization. We say you have to use that for 2 weeks minimum. 2-week minimum, okay? So there you go. So the score is 3 for this, fake patient, all right? That one puts him in a moderate category in the recommendation there. And we do this for every patient, okay? But honestly, every patient that comes here is going to not have a score greater than 4. Otherwise, then we're not going to be, able to do the surgery, okay? And as we saw there, for patients that have that score, SCDs are what was recommended, and we recommend to do it for a minimum of 2 weeks. You can do it longer, but no less than 2 weeks.
Are there any, thank you for that, are there any pre-op things that we can do to prevent DVT or PEs?
Yes, all this stuff. You stop your estrogen, you stop your nicotine, okay? Those are the main things that you have to do. And then, of course, you have to make your commitment to moving around after surgery, all right? And what else? And then, in terms of flights, that's okay. You're going to come in, but you're not going to leave until at least post-op day 5. That's the key part right there, okay?
How soon should you move after surgery, and how often? How do you know if it's too much or too little?
Great question. So you start from post-op day 0, meaning day of surgery. So post-op day 0 is the day of surgery, post-op day 1 is the following day. So you should start to move around from post-op day 0, okay? And we recommend to walk at least 10 minutes every hour while awake, okay? You can walk longer if you want, but no less. How do you know you're doing too much? If you're walking at a kind of just a regular pace, there's no such thing as walking too much. You can walk as long as you want. What we don't want you doing, of course, is strenuous activity, heavy lifting, running, jumping, jogging, or anything like that. But walking, there's no restrictions there. Okay. And like I said, if you're having, especially something that involves a tummy tuck or a mommy makeover, then you're going to have your sequential compression devices. You're going to use that certainly while you're sleeping, when you're not being reactive, and for all travel.
Why are tummy tucks at a higher risk than, let's say, BBLs or any other surgeries?
Okay, great question. So it comes back to a little bit of this here, stasis. Okay. So when you do a tummy tuck, right, the patient is kind of walking around, postpartum and whatnot. They may have some muscle weakness, some muscle separation, okay? But when you do a tummy tuck, part of the tummy tuck is to do that muscle repair, right? And when you do that muscle repair, you're tightening things up in the belly. We're doing that to get that nice flat abdomen, okay? But when you tighten things up in the belly, then you're, by definition, increasing some of the pressure inside the abdomen. And so this blood that needs to come from the legs all the way back up to the heart obviously has to pass through the abdominal area through what's called the inferior vena cava, which is a large vein that gets to the heart. Okay, and there's a little bit more pressure there, and therefore there's a bit more stasis. So that's one contributing factor. And then the other one is, of course, ambulation. So if the patient, says that they're in pain and they don't want to move around, then they don't ambulate the way that they should. Okay, that leads to, again, immobility, which leads to stasis, which leads to clots. So those are the two main reasons. So what's super helpful? Exparel. We recommend all of our patients to get Exparel. Exparel is an injectable pain medication that we put at the time of the tummy tuck along the muscle repair and along the incision to greatly decrease the pain, especially in the first 72 hours. And so that then allows the patient to more comfortably ambulate the way that they should. Okay?
Thank you very much. There are a few questions, a little off topic.
Yeah, sure. We'll take any topic right now.
All of them.
Yeah.
All right. Can I combine upper back lipo with my mommy makeover?
It's only in very specific patients. Okay, remember, here in Florida, the maximum amount of fat that we're able to liposuction at the time of a mommy makeover is only 1,000 cc's. That's not a lot of fat for most patients. Okay, so for most patients, we can get that out of the flanks and the waist, and that'll help contour the body. Okay, and then we don't really have anything left over to go to the back and take out. Now, if you're a lower BMI patient, say your BMI is at 22 or 23, and really your main issue is just loose skin and you have a little bit of extra fat in the back, then for those particular patients, then it's a possibility, as long as we don't go over that 1,000 cc limit.
How long should I stay post-op after liposuction, and should I still wear the compression devices to lower the risk of blood?
So like any surgery, whether it's lipo, mommy makeover, etc., even a simple breast augmentation, okay? Even a simple breast augmentation that took 30 minutes, you are not to fly home before post-op day 5, okay? For all the reasons that we stated here, all right? So you're gonna stay here at least 5 days post-op. That's the bare minimum, all right? And then your compression stockings, you're gonna use that for 7 days.
Thank
Compression
you.
stockings for 7 days, and then the SCD machine, if you have that, 2 weeks.
Thank you. I love the way your BBLs look natural in proportion to the bodies. I had a BBL 3 years ago, and unfortunately, it's way too big. Do you perform BBL reduction?
So we certainly do the procedure, but of course it has to be for the right candidate. So what I would recommend is that you go to our website, which is www.pureplasticsurgery.com, and you hit the virtual console button, and of course fill out all your information and send your photos so that I can make an evaluation and determine whether I believe that we can, help you in a way that you'll be happy. So it is a little bit on a case-by-case basis, but we certainly do that procedure where we kind of do BBL reductions and reshaping procedures.
Thank you. Next, another, let's see. All right. I had a BBL a year ago. I wasn't planning on getting pregnant, but I'm pregnant. Will this affect my results?
It will to a certain extent. Okay, so now you had a BBL a year ago. You're pregnant now, so whatever fat that that was transferred and that took and survived, well, that fat's just part of your body now. So that fat's going to be there for forever. So in that sense, that fat's not going to go away. But of course, with pregnancy, typically there's multiple hormonal changes and there's weight fluctuations, and that can certainly affect how the body looks afterwards and potentially how quickly it bounces back. So what I would try to recommend is that, of course, you want to have a healthy pregnancy, and there's going to be a certain amount of weight that you're advised to gain by your obstetrician to keep the baby healthy. But try to not go over that, right? Try to not just gain tons and tons and tons of weight, because that's really going to affect your body for the long term.
Thank you. Maybe I've read too many horror stories, but is it a possibility for somebody to wake up during surgery?
Typically not with general anesthesia. Okay, so when we have our patients under general anesthesia, that means they're completely asleep. They're not breathing on their own. We put the tube in, what's called the ET tube. Okay, and then they have all the medications and gases that kind of keeps them asleep throughout the entire surgery. Now, if you're having a procedure under what's called twilight anesthesia, that means that you're not completely asleep. Okay, you're just kind of sedated. All right, and so when you're having procedures under MAC or twilight anesthesia, then yes, sometimes you can gain consciousness in the middle of the procedure.
Thank you. All right, another great question. I've had liposuction to my abdomen 2 years ago, and there's a lot of indentations and irregularities. Can you fix that, please?
So again, we'll need further evaluation to make sure, but a lot of times we can fix it, but the key thing is to identify what is the underlying issue. So is the unevenness due to fibrosis or basically fat pockets that are left behind? Or actually what's more common is that the unevenness is due to loose skin laxity. That's actually the most common reason for that. So it's because then the treatment is completely different. If the issue is fibrosis or pockets of fat, then further liposuction will help. But if the issue is skin laxity, then what will help then is going to be either a mini or a full tummy tuck.
Thank you. After a BBL, what's the recommended time to wear a faja, and is it okay if I wear it long after that recommendation?
Okay, so for the first 6 weeks, you're going to wear your faja night and day. Okay, you take it off basically just to shower to wash it. Between 6 weeks and 3 months, then you're going to scale down to 12 hours a day. And then for most patients, at about 3 months, you can be done with the faja altogether. Now, there are some patients that do have some residual swelling. Maybe they heal not as quickly, and that's okay. Not everybody has to heal at the same rate. And you can keep using the faja for longer. So there are some patients that can use their faja for 6, 8, I've seen even up to a year using the faja. But like I said, anything beyond 6 weeks should only be about 12 hours a day, and you don't really need to use it any longer than that.
Thank you very much. I think we got them all.
We got it?
Yes,
all
sir.
Right. Awesome. So I hope this was very, very comprehensive. Okay, regarding the clots and regarding pretty much anything that has to do with it. So I hope that answers all your questions regarding this. And then we're happy to, of course, take any other topics you guys may be interested in. So just check out our IG. A lot of times we ask you for questions and topics so that we can then present them to you here on our Hump Day Live. Okay, everybody? So I look forward to seeing all of you next week on Hump Day with Dr. Alex Earle. Ciao.